Welcome. Good morning, good afternoon, good evening, wherever you are calling from. And welcome to this fourth and final session of oral presentations on COVID-19 at ICPE 2021. My name is Christopher Wrench. I am an assistant professor at the London School of Hygiene and Tropical Medicine and Yale School of Medicine. And I have the privilege to co-moderate this session called COVID-19 Potpourri, Vaccines, Long Haulers, and the NFL, with Professor Fredrik Nyberg. Fredrik, would you like to kindly introduce yourself?
Yes, thank you. I'm Fredrik Nyberg, Professor of Registered Epidemiology at the School of Public Health and Community Medicine, Institute of Medicine at the University of Gothenburg, Sweden. And I'll be moderating the second half of this. So Chris will start us off.
Brilliant. Thanks, Fredrik. So we have an exciting session planned with 6 presentations. We are having technical difficulties with 2 who are, I think, attempting to join. So we are going to make do with all of the fun technical advances we've got these days and try to get them on board as we are going through this session. I will introduce the first couple speakers and then pass over to Fredrik to introduce the last few speakers and close the session. We have asked each presenter to keep to about 10 minutes to deliver their presentation, which should allow around 5 minutes for questions and answers for each presenter. And so for those of you in the audience today, both Fredrik and I will be monitoring the chat and Q&A boxes for your questions. So please do feel free to send your questions as they occur to you during the presentations. We'll then put your questions to the presenters when they finish. And just to note that we may save more general questions to put to all presenters at the end of the session in a general Q&A. So with that, I will now turn it over to the first speaker, Shinton Lee, who is a PhD student in the Pharmaco and Device Epidemiology group at the University of Oxford. Shinton will kick off the session with a presentation on descriptive epidemiology of adverse events of special interest for COVID-19 vaccines across 7 countries and 4 continents. Shinton, you now have the virtual floor, and thank you again for your perspectives.
Okay, thank you, everyone. Thanks for the introduction. Let me share my screen for the presentation. Yeah. So, hello, everyone. I'm Shinton Lee from the University of Oxford. Thanks for the opportunity to present these works, representative of my colleagues and writers and authors. And here's my disclosure. So since the approval of thorough vaccinations from December last year and a large immunization program ongoing, we are now seeing there are more and more news raised about safety concerns for the vaccines on the media. So when talking about the safety of vaccines, especially the COVID-19 vaccine, there's one term I want to introduce, which is adverse events of special interest. So that's a set of adverse events that's been precisely specified that can occur coincidentally in the population, but as well also considered to potentially related to one of the COVID-19 vaccines. So there's 2 terms. One is background rates, which is the incidence rate of these events that generated from the population without the vaccination or before the introduction of vaccination. And we also have another word is an observed rate. So that's the incidence rate of those events acquired among the population who got vaccinated. So yearly, the background rates can be generated from either literatures, from real-world databases, or some other sources as well, while the observed rates are yearly from post-marketing surveillance and self-reported data or routinely collected healthcare data. So one way to think about the safety of the vaccines is comparing these 2 rates to see if any difference with the background rates versus the observed rates. So this can help us to identify some potential safety signal. So these methods have been used in safety surveillance, and here's an example from the UK that the expected rates and the observed rates for Bell's palsy has been comparing when examine the safety of one COVID-19 vaccination. So before we applying this message to all this COVID-19 vaccines and the potential outcomes, and is essential to understanding how the background rates look like. So therefore, we conducted this study, and our objective is to estimate the background incidence rates of a set of selected adverse events of special interest, and that's potentially associated with the COVID-19 vaccines. So methods. This is a retrospective cohort study. It's a network study that we included a total of 13 databases from 8 countries and from 4 continents. And all of the data are mapped to observational medical outcomes partnership common data model. So here's a view how this included databases geographically look like. So we have databases from an American, from Europe, from Japan, and from Australia as well. We included 5 claims data and 8 electronic health record data. So how we define the study? The study period is from 2017 to 2019, the end of 2019. We require a 365 days claim period, and also a continuous enrollment for the individual to be included in the cohort for that year. And we estimate the incidence rates for each of the cohort. So the outcomes of interest here, including 15 events that is generated from the one of the protocol that's released by the FDA earlier this year on monitoring COVID-19 vaccine safety. So we estimate the incidence rates and also stratify the results by the age and by sex and also by databases as well. After that, we pulled all the incidence rates together and from different databases using a random effect analysis, and also classified the incidence rates based on the internationally accepted classification method. So the results, in total, we have included more than 100 million people, and they contribute to more than 200 million person times of follow-ups. So two aspects of the results we find. One is there are within sources and population level heterogeneity, which is the age and sex pattern for incidence rates. And beyond that, we also find there are population level heterogeneity, that is the difference of the incidence rates between databases. So this is the pooled incidence rates, and they are classified based on the concept of International Organization of Medical Science. So the colors from the green range means the events are very rare, and to red, which means it's very common. So just a general look at this very colorful table, you can see those events we included here and by different age and sex group are ranging from very rare to common. So let's look down into one example here using acute myocardial infarction. So we see for this single disease, it can be classified in very rare among the very younger population to the common group, which is orange color for the elderly ages. So this tells us that for the classification of the adverse event incidence rate, a single classification is not enough. We must considering the difference in age and also in sex patterns. And also let's look at the database and level estimation. So the plot here, there's many dots, but one of the dots representing the incidence rates for each disease, estimating from one databases. On the x-axis, we have age and sex, and the y-axis is the incidence rates. So we can see there for diseases like encephalomyelitis and Guillain-Barré syndrome, we see there's a age trend, age pattern available, but that's not too obvious for narcolepsy or transverse myelitis. So the age trend is more obvious in this set of outcomes, which are mostly cardiovascular related. You can see the incidence rates of this outcomes increased with age. And we also see that for almost all of the outcomes that the triangle dot is higher than the round dot. So which means the incidence rates are for the same age group are generally higher in the male rather than female. And that's the last set of outcomes. We also see the age patterns for appendix and Bell's palsy and but not too obvious for the other three outcomes here. So let's look down into only one outcome here, which is the ICS example here. So I have highlighted one column, and so that is for the females among age 65 to 74 group. So all the dots as represented one estimation from a single participant databases. So we could see that for this specific age sex group, the incidence rates for the event could ranging from below 1 to over 100. So this tells us that there are heterogeneities of the incidence rates, which is beyond the age and sex level, but that's the difference between the databases level. And we could see the similar thing for other groups as well, and in the previous slides I presented for other outcomes as well. To put this all together, we saw that age is a strong fact, and for estimating incidence rates, that we must adjust for it when calculating the incidence rate. And also we observed there are large heterogeneity between databases. So this tells us that if we want to conduct a study that comparing the background rates with the observed rates, and we should consider doing a race in databases comparison. And also, if we got one estimation of the incidence rates from a single study, we must be very crucial when interpreting results. So the data, the paper has been published, and which is available here. And we also made an online app for explore the results, which I can show here. So in this online app, we could select the outcome, the 6 age groups, and also by databases to filter out the results of interest. And we also have the definitions for each of the outcomes and the detailed explanation of the data sources, and in this online web as well. So please feel free to explore that website. And I'd like to thank my supervisors and all my collaborators. So I'd like to take any question. Thank you.
Thank you very much, Shintong. That was quite impressive how much data analysis you were able to concisely communicate in your presentation. I'm looking for any questions from the audience. I'm not seeing any at the moment. So if you're in the audience, please do send the questions in the Q&A box as you have them, and we will make sure we put those to the presenters. Suppose while we wait, I can ask a couple. As I said, it's quite impressive how much data you were able to incorporate in your analyses through this, this platform. I wonder what were the key challenges in either accessing, using, or analyzing the data across so many data sources, and particularly how did you overcome them?
Okay, thanks for the question. So as introduced, the studies is conducted within the OPSI community. So all of our participant databases are mapped to a common data model. So this allows us to apply the same analysis code across different databases and to gather the results together. So one of the key challenges, I think, is when we're defining the result, defining the outcomes, and because although all the data is mapped to the common data model, since they came from different source code, that we need to diagnostic on when we need to have some diagnostics steps to see if our definition for the outcomes do work in each of the databases. So we have a process called cohort diagnostic that we have a set of analysis that we distribute to all the data partners that they run it, and we can have a result returned to us to see how each of the outcomes definition works in each of the databases. And if we see some obvious problem, we need further adjustment for that. So yeah, thank you.
Very useful to have a common data model across these data sources. We have a question from the audience. Thank you, Nancy. I'll put that question to Shintong now. Shintong, how consistent were results across databases? Were there some outcomes that were less consistent or most consistent? And were the outcome definitions validated in any way?
Okay, thanks for the question. So we do see some outcomes are more like consistent across databases, while some others are not. So for example, we see we saw most of these cardiovascular events are like more consistent, but for some events like anaphylaxis or narcolepsy, that's like maybe have different diagnosis process in each country participated, or they use different definitions. So we saw that the dots are more like spread between the databases. So the outcomes are not like validated as the traditional way we said, that we conducted a comparison study. We compare the code we have here, the patient we identified versus either like chart review or electronic health record review. But we did conducted like internal process that we examine all of the outcomes definition in each of the databases to see if they match our background knowledge. That we, for example, for one disease we selected, for example, myocardial infarction, we will gather information for the patient's diagnosis, recent diagnosis, recent medications, and stuff like that. So we could understand better the cohort of with the people with outcome we capture is the population that we wanted. Yeah, thank you.
Shintong. We've got a couple more minutes left for you. I might just put this one to you. You know, thinking of the plenary that we had on day one on equality, diversity, and inclusion, and making sure that we're including data sources that have been historically excluded. I wonder if there are any plans, you know, not to take anything away from your analysis, which is already spanning, I think, 4 continents. But are there any plans to incorporate data from other parts of the world that are currently not captured in your data source?
Yeah, absolutely. So since our this study are completely open sources, we have our source code available and on GitHub. So all the data partners are more than welcome to run our analysis in their own data, which are obviously shouldn't be mapped to the community model at first, but they are more than welcome to share the results with us, and we can able to integrate the new results and see how it looks like. So yeah, if anyone in the audience are interested in conducting a study with your data, please contact us. Thank you.
Thank you, Shintong. Frederick?
Yes, I have a question too. So I was wondering, did you look at the years separately to sort of see if there are any of these outcomes had time trends over the years or differences, large differences between years? I'm thinking of this particularly because, well, years could be different, but also the year when COVID happened and the year now following when the vaccinations are happening are perhaps likely to be different years. And so it would be good to know something about annual differences.
Yeah,
so
thanks for the question. So for the study, we haven't done any stratification by years, unfortunately. But the study period for this study is 2017 to 2019, so which the end of 2019, so which almost like exclude the time that after the COVID pandemic started. So this could minimize the impact of COVID on the diagnosis pattern, but we didn't done any time trend in this study so far. Thank you.
Sounds good. Thank you, Shintong. Thank you very much. We will now turn to our next speaker, Kuo He. Kuo is at the Gilling School of Global Public Health at University of North Carolina, Chapel Hill. He will help us understand the impact of COVID-19 social distance restrictions on hospital encounters due to injury by poisoning or toxicity of medications or non-medicinal substances. The virtual floor is now yours, and thank you for your perspectives.
Can you hear me?
Can do, yes, and see the slides perfectly. Thank you.
Okay, yes, thanks. Yeah, it's Kuo. Thank you. Yes. So I'll be talking a little bit about the unintended consequences in line with the last presentation. Let me see if I can move the slide forward. Not working. Okay, so these are my teammates. We have no disclosure specifically. And a little bit of recap of what happened is that COVID-19 appeared in 2019 in December, and then we had our first case in the United States in January. In March, the World Health Organization declared COVID-19 as a pandemic, and the United States declared it as a national emergency. In the month of March, there was a number of different stay-at-home orders or social distance restriction mandates. California was the first state to do so on the 19th of March. And for this study, we are interested in North Carolina, a state in the borderline south of the United States. They had their stay-at-home order or social distance mandate on March 30th, 2020. And then afterwards, there were different flavors of this as we progressed throughout 2020. So the intention of these social distance restrictions, orders or mandate was to reduce the transmission of the coronavirus. And there are potentially unintended consequences during this time that are unknown, but during this time, of course, there were some increased call volumes to poison control centers throughout the United States, depending on the state that you looked at. And these quantitatively, we are unsure of what social distance restrictions were doing to injuries, specifically when it came to medication or non-medicinal substance. So we set out on this journey to evaluate the impact of social distance restriction on healthcare encounters due to poisoning and toxicity of medications or non-medicinal substance in North Carolina. And what we did was that we identified all healthcare encounters with a principal diagnosis indicating injury by medication or non-medicinal substance using ICD-10 codes between 2018 and 2020 in the North Carolina healthcare system. And then we computed 14-day counts of injuries throughout the study period. We defined the period from January 1st, 2018 to March 29, 2020 as the baseline period, and the period after that as the social distance restriction period. We perform a series of interrupted time series analysis using quasi-Poisson regression models to evaluate the trends and changes in the counts of and rates of injuries post the social distance restriction order in North Carolina. And when we're required, we control for autoregression with lag terms and seasonality with the four-year term, and then we use volume of healthcare encounters as the offset to model rates of injury. So results. What we saw was that there were approximately in North Carolina healthcare system, there were approximately about 500,000 injuries that are related to medications or non-medicinal substance during this time period. Of those, about 40,000 were principal injury diagnoses that belonged to about 20,000 patients. And there were, when you stratified these counts by the different years, you can see, I mean, it's 3 data points crudely. You can see that there was this upward trend. And then 2020, that the numbers actually, the counts actually decreased. So what I'm going to do is I'm going to present counts and rates from the interrupted time series for non-medicinal substance, and then just summarize for the medications. For non-medicinal substance counts graphically, this is what the 14-day counts look like. You could see that there's a pronounced seasonality trend here, and with time series data, there's autocorrelation. These are the autocorrelation plots from this particular model. I would call this like the base model. These are the residuals plotted using an autocorrelation function. And you can see that there's, seasonality, maybe some autocorrelation more or less. You can never really rule that out. And then, so we went through a series of models to try to first address the autocorrelation and the seasonality, and we settled on a model that had 1 four-year term and 1 lag term. And the autocorrelation plot improved. There's the seasonality is a little, in theory, disappeared. Graphically, the interrupted time series analysis, this is what it graph outs to be. On a quantitative context, our model looks something like this. And when we would interpret this is that every 14 days, there were approximately 64 non-medicinal injuries resulting in healthcare encounters. This was a non-statistically significant trend over time. And then when the social distance restriction were put in place, there was actually a drop in the number of encounters by about 34%. But post those restrictions, there was actually the time trend actually increased by 4.2% every 14 days. From a lay terms, this if you look at this time period of July 15th to the 28th, after the social distance restriction mandates in North Carolina, the actual raw counts kind of more or less are similar. So you see that initial drop, and then there's like a rebound in the counts as time progressed. For rates, graphically, this is what the rates turn out to be for every 10,000 healthcare encounters. We also settle on a model that looks like the one for the counts with one four-year term and the lag term. And graphically, the interrupted time series analysis looks something of this nature. Quantitatively, these are the beta estimates for the coefficient. And when you interpret them, you see that there's an underlying rate of injury by non-medicinal substance that appear to be decreasing over time, roughly 0.4% over time every 14 days. And then when social distance restriction mandates were in place, there was a non-statistically significant drop in about 22%. But then with the social distance restriction, I would more or less categorize this as a rebound by 2.9% every 14 days. And then also in the same context, as time progressed, the rates resumed to what it was prior to the social distance restriction mandate. For counts and rates related to medicinal substance or medications, we settle on a model that did not have to control for seasonality or autocorrelation in terms of a lag term. And there was an increasing time trend over time. Social distance restriction did decrease the number of counts by roughly about 13.6%. And then for the rates, there was also an increasing time trend over time. And then social distance did not have a statistically significant bump in the rates, but then you could see that there was approximately an 11% increase in rates, but then the time trend over time actually decreased that by roughly about 1.8%. And that the rates kind of resumed to what it was prior to the social distance restriction period. The limitation of this linear model is that you don't see that it cycles back and forth. So what my conclusions and takeaway from this study was that the counts of injuries, social distance decreased the counts of injuries, but did not have a significant impact on the rates of injuries. As time progressed, throughout the social distance restriction period, the counts and rates moved towards the counts and rates in the baseline period. And my kind of thought on this is that the initial decrease in the counts of injuries are likely being triaged to poison control centers because people aren't going to the ERs or they're not seeking care. But as time progressed, it kind of resumes to what it was prior to the mandate. I would take any questions.
Thank you, Kwa. Very interesting presentation. We do have a couple questions. Maybe the clarifying question first. In the Q&A, what was the name of the data source for this study that you used?
We used the electronic health records in the North Carolina healthcare system. So it's a statewide with 14 or so hospitals.
Okay, so all the diagnoses codes that you're using are therefore, they're all based with hospitalizations. None of these are diagnosed in outpatient capacity.
Yes. No, it does include ambulatory care. So you have your ERs, your ambulatory care, your observational stay.
Great, thanks, Claude. We are going to attempt, I see Jacqueline Bosco with a hand up. Perhaps you can come off mute now and ask your question.
Hi, sorry, that was a glitch there.
Well, nice to hear an attendee's voice anyway, but there you go. So all attendees, if you'd rather not type your question and ask your question with your voice, you are permitted to do so. Please do raise your hand and use that function. Frederick, just let you come on.
Yeah, maybe I can just ask a very brief question. So what do you think, what are the implications of your results? How does it say anything about how these types of events should be managed in the future in this type of event?
Yeah, I was trying to think about that. I think the key takeaway here is that the studies that are from the Poison Control Center, and this is actually, there are studies in France, there's study in Sri Lanka, they all demonstrate, there's uptick in calls to the poison control centers. So I think that if we had to do another social distance restriction mandate or period, I would staff those poison control centers appropriately, because I feel from our study is that the events that are not significant are being triaged through the poison control center. I don't have data from poison control centers in North Carolina, but subsequent states like Texas and California, they see this uptick specifically during the first few months of their particular social restriction period.
Okay, thanks.
Thanks. I had a quick one while we have a minute or two left. Could you comment on what you think the mechanism is between social distancing restrictions and the outcomes that you assessed? In other words, is social distancing restrictions a proxy for something else that's actually at play, or is it? Can you comment on whether it's the social distancing restrictions themselves?
Yeah, that's a good question. I'm actually not sure. I mean, like using the interrupted time series model, I think that or the methods, I think we could potentially rule out some other factors that particularly at play, but I don't have another explanation other than, I mean, maybe I guess social distance restriction probably just, it's people aren't going in for maybe their poisoning or their side effects attributed to their medications or whatnot. But yeah, I think that still has to be investigated. We do plan to do sub-analyses like with intentional poisoning or unintentional poisoning, bar the limitations of the data. So I don't really have a strong answer for that, but I mean, like, there's only one thing that's going on during this time from March 30th to, there was different flavors of social distance restriction, but in that first few months, you see like there was pronounced, like for this, for non-medicinal substance, you can see that throughout the time period, there's different flavors of social distance restriction, and it kind of rebounds back to what it was prior to that. So the only thing I could really say is that stay-at-home orders were in place, and that might explain this triage. Yeah,
Really interesting points. A very quick one for you. We had a question from the audience from Syed Rahman. Did you have the opportunity to look at the death due to poisoning during this time period as well? So death due to poisoning as your outcome.
Yeah, we didn't have that data, but then the ICD-10 codes, they do have the, they code for different like intentions. So that's probably what's planned next, but there's no data on death in the EHR data. Not to my knowledge yet.
Right. Thanks, Kwa. Very interesting. So now we will turn to our next speaker, Dr. Christina Mack. Christina is Vice President of Epidemiology and Clinical Evidence at IQVIA. And for those who have been curious about what the US National Football League have to do with this session, wait no further. Christina will share how the NFL played a role in understanding population testing for COVID-19 and whether a rapid antigen test can rule out infection. Christina, the virtual floor is now yours.
Perfect. Hi, everyone. Can you see me and hear me?
Can see you, can hear you, and can see the slides.
Okay, perfect. Well, so you can see my wonderful co-authors, and I want to thank them as I represent their incredible on-the-ground epidemiology as well as their research work. My disclosures are that I'm a salaried employee of IQVIA. I'm going to talk about a lot of diagnostic products today, and I do not have stock in any of those companies. So thank you for the introduction. If you have been curious about sports and what sports have to do with science, and maybe you just saw the Olympics come to a successful completion, what I'm going to talk about today is what we've learned from sports. And what you see on the screen right now is one of my favorite articles about science, where they talked about, evidence, real world evidence can come from many different places. And in the era of COVID-19, as you're seeing here today, it's coming from some new places and some unexpected places. The publications that you see on the slide are only a sample of the publications that have come out of the NBA, which is the US National Basketball Association, the NFL, which I'll talk about today, the US National Football League, as well as many other international sports organizations across rugby, in England and others that have tested their athletes so often during their seasons, contact traced, and really worried about understanding transmission to the extent that they got to every single detail. Sports has really been able to contribute much more about epidemiology and science than they have arguably in the past. For us who are here talking about pharmacoepidemiology, sports has been able to comment on the effectiveness of diagnostics as well as vaccines that were approved under emergency use or under rapid approvals and then used very broadly in really an unprecedented way in the real world. So today I'm giving a somewhat narrow example, and we'll talk about antigen point of care tests, which I have a feeling everyone here has encountered in an effectiveness kind of a way, both in your work and your research, as well as probably in your personal lives over the last year and a half. And I'm talking about that in the setting of the National Football League, which is American football, and the National Football League Players Association, which is their union that represents the players. And we're going to talk about their screening and testing and what we've learned from that. Importantly, this is built on a real world evidence database. And the data here to me is one of the most fascinating data sets and the most complete data sets that I've ever worked with, which is why I think we really were able to make some strong understandings about, have a strong understanding about the diagnostics that we were looking at. The reason the data set is so important here is that they were testing everyone every day as part of screening and then doing confirmatory testing after that to make sure it was not a false positive and understand the real outcome of those individuals. There were behavioral protocols such as masking and distancing that were governed by devices. So we have wearable devices in this ecosystem, as well as contact tracing, so that we really understand, were you together when you weren't wearing your device? Were you wearing your device but you weren't really together? And were you masked at this time? So really understood the test results and then also the outcomes and how that transmission may have occurred. Because of the reason I think sports is able to speak to this is because they have a business reason to make a really big investment in RWE that some of our other community settings, such as schools, maybe needed to do, but really didn't have the ability to make that investment. So sports was using new diagnostics, which I'll talk about in a minute. They were putting them through daily testing. They did complete clinical follow-up and adjudication of all test results. So they knew true positive, false positive, et cetera. They're a big ecosystem. What I'm going to talk about today in the study is a 12,000 person closed cohort with full follow-up information. And then they deployed wearable devices as well as epidemiologic investigation and documentation alongside all of this. Importantly, and what we'll talk about today, is that there were analytics going on in this real world evidence database at the time of, so we really were understanding the effectiveness of these diagnostics in practice in the real world, and could make operational updates based on that to keep these populations safer. So
Hey,
this is what
Christina, so sorry to interrupt. We've been getting a couple comments about sound quality, and it seems, and I really want people to hear this really exciting presentation. So I wonder, it seems to be better when you're closer to the, wherever the camera is. It kind of pops in whenever you're closer.
Is this better?
It is.
Okay, perfect. Thank you for letting me know. So the database that I was just talking about, that I hope that you heard about, is here listed on the right. I won't go into too much detail, but I know that at least a portion of the people on this call care a lot about, how does that data come in? How does it get put together, documented, streamlined, curated? So the points I want to make about the integrated data source is that we were integrating constant lab results. They came in 24 hours a day with terabytes of wearable data, symptom screening, and behavioral compliance from contact tracing reports. And what we did was we harmonized all of those based on a common ID into one real-world data set. We created variables that we could, of course, do the analysis on, and then kind of curated, cleaned it on a weekly basis, and documented all of that so that we had a real-world evidence hub that we were able to turn results around very quickly. Again, for purposes of this presentation, as well as operational purposes, to do research and understand if these diagnostics work in asymptomatic populations, broad populations, daily testing, things we really didn't know when they went through these emergency approvals. So what diagnostics am I talking about? There were 5 diagnostics that were part of this ecosystem. I'm going to be focused today, if you look down at the lower left-hand corner, on the Sophia antigen point of care test, which was the primary point of care test from July through November of the football season. Based on the results you'll see today, we did eventually transition to a different point of care, but the Sophia antigen is the diagnostic that I'll be focused on today. I'm going to show you comparative test results with both 24-hour RT-PCR tests, or NAT testing, as well as adjudicated status. And those, let's call them the gold standard lab-based results, are either a Roche machine, a Hologic machine, or a Thermo Fisher machine. And all of those had a 24-hour turnaround, but those were sent out to the lab as opposed to the point of care test, which was the Sophia antigen, our focus today. As I said, this is a real world data set, and we have over 1 million COVID tests. So 5 different machines are all pulled together to give us a data set of 1,060,000 PCR and point of care tests administered, again, over 12,000 players and staff in a closed cohort. That goes across 32 different teams, which in this case, you can think of that as kind of 5 diagnostics across 32 different geographically distributed communities. And so we really have a broad generalizable population here in terms of geography. Now, it's largely male, it's largely young, but we have staff, and we actually have a pretty good age range here. So we do consider these communities. Now, speaking of the community, what was happening in the community at the time? The individuals in this cohort were living at home. They were not in a bubble, as some of the sports have tried to kind of pseudo create. So if you look on the left side of the graph here, you can see what was happening in the community during the study time period. We thought we had a lot of COVID, and then we climbed up a big COVID mountain, and we really had a lot of COVID right in the middle of the season, which is why we were able to comment on the effectiveness of these diagnostics. And then you can actually see on the left the regular season cases in the NFL ecosystem. So you can see that those follow the community cases, where we started to see outbreaks and clusters and high numbers right where the community started to issue, as you would think. Here's that information again, and this study goes through the early part of January, and the reason is that the football season ends at that time and goes into playoffs where we have fewer clubs that are playing. We talked about the Sophia point of care. We use the Sophia point of care test only basically on the left side of this graph up until the end of November, at which time the results I'll show you today motivated us to stop using that antigen point of care and start using an RT-PCR based point of care test, which we're still using today. So the objective of the study is to characterize the performance of a single antigen point of care test conducted within a daily testing environment and compare that with the same day lab-based NAT results, as well as the medically adjudicated case status. I've talked about the methods, and so the big thing that I want to put forth here is that the point of care tests in this setting were not used for the daily testing. That's what the NAT or RT-PCR tests were used for. The point of care tests here were used for cause, confirmatory testing after a positive NAT result, after a known exposure to COVID-19, clearance for entry to a facility if for some reason we didn't get that NAT result test back, and then someone who's newly symptomatic but hadn't received a positive test result yet. So generally here we're using them early in infection and in A or pre-symptomatic individuals, which again is kind of outside of the scope of those emergency use authorizations and why this is really important research. I talked about the data collection. I'm just going to touch on the symptoms. We pulled those from contact tracing and entered them into that linked data hub. So that was a patient reported to a tracer or clinician reported outcome, and then the outcomes were medically adjudicated individually by trained staff, always a clinician and an epidemiologist, as well as a tracing team and the team orthopedists or medical providers. So we have 90%, over 90% of our initial tests were adjudicated as false positives, confirmed positives, or viral shedding. What I'll report today are rate of agreement between tests, which is the kappa. I'll talk about sensitivity and specificity, as well as negative predictive values and positive predictive values. And I'll talk about those in the context of both the NAT result that was done on the same day, as well as that clinically adjudicated case status, and then give you a little bit of context from the Roche machine on how that aligns with CT values, which is a quantitative value of how much virus, as well as symptomology. So this is the performance of the Sophia antigen point of care test against the same day NAT. And you can see that the kappa or the agreement was 0.62. The sensitivity of the antigen point of care test was 50%. The specificity was 100%. We had a false negative rate of 48.8%. So if that kind of makes you feel concerned, we felt concerned about that as well. When we compare it with adjudicated case status, not just the same day test, because that is, of course, assumes that same day test is always right, that sensitivity did go up a little bit. There were days where the point of care test was right and it really wasn't an adjudicated case. It was a false positive on the NAT side. So the sensitivity went to 57% or 58% with that false negative rate at 43%, and still a very high specificity for the Sophia antigen test. So we want to look at these positive individuals in the symptomatic cases to see if having someone symptomatic might help the point of care test be more accurate. And what we found is that among those who were symptomatic at the time of the positive NAT result, we did see some better performance from the antigen point of care test. We had 35% false negatives as opposed to 44% false negatives for asymptomatic. However, we're still missing 16 out of 46 symptomatic cases when we use that antigen point of care, which is concerning, I'm sure, to a group full of epidemiologists on the phone. This splits the antigen point of care test true positive versus false negative by that quantitative value that only the Roche diagnostic gives. And so what you can see is that when the Sophia test was correct as a true positive, there were lower cycle threshold values. So for those of you who've been working in COVID, that's that a lower cycle threshold value is a higher viral load. Among the false negatives, when the antigen point of care missed an actual case, you see that those cycle thresholds were higher. So what that means is that the antigen point of care test is more likely to catch an infection when we have higher viral loads. But when you're in that lower viral load category where a lab-based test could pick it up or a PCR test could pick it up, that antigen point of care test was missing the infection more commonly. This is just kind of what it's like to be using this test during an outbreak. So in this table, each of these is a day and a case. And so you can see if you just go to week 2 that on a Monday, we had 8 cases. Every time you see red text, we had an antigen point of care test that missed a positive individual who was able to test positive on an RT-PCR test on that exact same day. So while we had these people in quarantine and it wasn't a danger, we were really able to see that the point of care, that the antigen point of care test was actually missing active cases during this outbreak every single day where the NAT test picked them up. And again, this is, I think, kind of the final nail in the coffin of us being able to use this for these really broad, close surveillance, broad population tests. So implications of this, because of that high rate of false negatives, the antigen point of care missed a number of tests. And we found that they had failure to identify and isolate cases early enough in this particular setting where people were still gathering at the office. And it wasn't able to help us prevent transmission. And so we did move to a different test. Disclaimer here is that we really were doing very tight surveillance. And so often these individuals were early in infection, they were asymptomatic or pre-symptomatic. So this really doesn't represent what it might look like if you had a lot of symptomatic people in the middle of infection come in and get an APOC, but it certainly does bring up, making sure that we're using these in the right settings and interpreting their results in the right way. No one in this population was vaccinated. We were using this in the wild type. This was pre-Delta, largely healthy workers, so it really doesn't generalize to immunocompetent individuals. We have young adult males overrepresented in this population. And in conclusion, we found that routine testing and broad population surveillance was really required a highly sensitive RT-PCR test. That was our most effective tool to prevent transmission. And with that, I will take questions.
Thank you so much, Christina. Yeah, that little shift changed, helped. But then about a few minutes after that, something just clicked with your microphone and it was crystal clear the remainder of the time. So that's great. We do have some comments from the audience. All caps, extremely cool stuff, Christina, from Danny. I don't see any particular questions. Noting, one just came through. Perfect timing. So I think you were commenting on, the generalizability to the current conditions with the Delta variant when we're just wrapping up. But Michelle has asked, how do you think Delta variant might change this, given the apparently similar viral loads in asymptomatic individuals in the first 6 days?
That's a great question. And you might, for those of you who were very involved in diagnostics in this space, you might remember there's a test called the Acula Mesa, which actually was what we went at the point of care test we actually transitioned to after using the Sophia antigen point of care and saw this. And that test was actually noted by the FDA to not be as effective for B117, potentially, which was the UK strain. Now, these are tiny samples, and so we didn't have this broad population surveillance, but I raise that, Michelle, because it really was kind of a point where we wondered if, as the virus changes, will all of our diagnostics work the same? So far, we use the Mesa and we have seen that detect cases very effectively. So I haven't seen that come to fruition for that test for any of these new variants, but I do think it's really important for us to continue to monitor that, because as the variants are interacting differently, obviously with our vaccines by manufacturer, I think there's a chance we could see that with the tests as well. I have not yet seen a detrimental effect of the variants on a diagnostic yet, but it is something I'm looking at on a weekly basis.
Thanks, Christina. Another one for you from Sasha Dublin. Can you give us any sneak peek into what the future might look like in terms of what the NFL might do next year for surveillance and what interesting questions it might help answer?
Sure, absolutely. So we are week 3 into the preseason of the NFL. We are very actively analyzing the data out of this data hub and trying to understand, right alongside the CDC and the FDA, what we need to do with vaccinated individuals, how often we need to test them, how we need to isolate them after exposure, when boosters are needed. So those are the questions that we, along with these, I think all of us are asking. I think from the NFL and from sports in general, we will be able to get some really strong real world evidence about vaccine effectiveness, because we will once again kind of have that 12,000 person closed population with knowledge of people's vaccination status, the date, the boosters, prior COVID infection, and adjudicated case status if they're infected. So I think we want to comment on that, and we'll certainly plan to do that if we're able to.
Brilliant. It's really exciting stuff. And we've got a comment, a question, a couple more questions coming through, but just in the interest of time and keeping on schedule, I think we will have to move on, unfortunately. So I don't get to ask my cheeky question that I wanted to ask, which is like, all the time we get to talk about internal and external validity and generalizability. And I wanted to think whether your results were generalizable to any other national sports leagues, but another time, So thank you very much, Christina. And I will now pass off to Frederick, who will introduce the next 3 speakers.
Thanks. All right, so let's switch gear a little bit then and move on to a couple of presentations talking about treatments and medications during the time of COVID. The first presentation in this series now is by Hemal Kumar Mehta, who's assistant professor of epidemiology at the Johns Hopkins Bloomberg School of Public Health. And the presentation is on the use of the hydroxychloroquine, remdesivir, and dexamethasone among adults hospitalized with COVID-19 in the United States. The results from the National COVID Cohort Collaborative, N3C. Please go ahead.
Thank you, Frederick. So on behalf of our research team, I would like to present our research work examining use of 3 drugs among adults hospitalized with COVID-19 in the US. And I would like to thank all my co-authors and National COVID Cohort Collaborative for this amazing research work. The funders had no influence on study design, conduct, or reporting, and all authors report no conflicts of interest. This research was published just last week at the Annals of Internal Medicine, so if you want to check it out. So globally, as of yesterday, more than 212 million confirmed cases of COVID-19 are recorded, including 4.4 million deaths. And in the US alone, we have over 38 million cases of COVID and over 630,000 deaths. There are several drugs for the treatment of COVID, but 3 drugs have been subject to particular scientific scrutiny. Hydroxychloroquine showed in vitro activity against SARS-CoV-2 virus, and the FDA authorized emergency use authorization in March 2020. And based on data from real-world studies on ineffectiveness and potential harms, FDA revoked emergency use authorization in June 2020. Second drug, remdesivir, based on preliminary results from ACCT clinical trial, FDA granted emergency use authorization in May 2020 and full approval in October last year. And finally, based on preliminary results from recovery trial, NIH guideline recommended the use of dexamethasone among patients who required oxygen support in June 2020. So despite rapidly accumulating evidence on safety and efficacy of drugs, little is known about how these drugs were used in the US, how these drugs were adopted in the light of emerging evidence, and in case of hydroxychloroquine, how it was de-adopted, and how drug use varied across different health systems. So to answer these research questions, we characterize the use of hydroxychloroquine, remdesivir, and dexamethasone to treat COVID-19. And we also described variation in the use of these treatments across health systems. So for this study, we use National COVID Cohort Collaborative, or N3C data. The N3C is a unique electronic health record repository supported by National Institute of Health in the US. The N3C represents the largest cohort of patients with COVID-19, with over 2 million COVID positive patients and their electronic health records in our database. So this retrospective cohort study included individuals with COVID-19, and then we subsetted patients who were hospitalized between February 2020 and February 2021. And finally, we excluded a few number of people who died on the same day of hospitalization because they were no longer at risk of receiving any medication. We had small number of patients with missing demographic variables, and we excluded children. So in the final cohort, we had 137,870 patients. We used inpatient medication records to capture the use of hydroxychloroquine, remdesivir, and dexamethasone. In terms of patient characteristics, we included demographics, body mass index, their comorbid burden, and measures on COVID severity, such as acute kidney injury or use of invasive mechanical ventilation or ECMO support. To describe trends, we use descriptive statistics and characterize trends. We superimpose these trends with selected FDA regulatory actions, such as emergency use authorization or revocation of authorization, full approval of drugs, and also major clinical trial findings. To characterize underuse of dexamethasone, we restricted our cohort to patients who were mechanically ventilated, and we also restricted our cohort to time period between July 2020 and February 2021. And in this time period and among this cohort, we determined what percentage of patients did not receive dexamethasone. The NIH guideline also recommended other glucocorticoids in the absence of dexamethasone, so we also evaluated other glucocorticoid use. And we used two-level hierarchical logistic regression model where patients were nested within health centers and calculated ICC, intra-class correlation coefficient, to describe variation. The ICC refers to underlying propensity to be prescribed medication due to systemic differences between health centers. So among 137,000 hospitalized patients, the mean age was 59 years. Half of the patients were female. Majority were non-Hispanic white. Nearly 2/3 of patients had one or more Charlson comorbidities, and 1 out of 4 patients had Charlson comorbidity score greater than or equal to 4. Overall, 9.7% patients were mechanically ventilated anytime during their hospitalization stay. Overall, 6.3% patients received hydroxychloroquine, 21% received remdesivir, 39% dexamethasone, and 17% of patients received both remdesivir and dexamethasone. So this figure shows trends in the use of hydroxychloroquine, which is depicted by green color. As you can see that earlier in the pandemic around March, the use increased and peaked at 42%. In late April, the use declined and reaching to approximately 7%. And once FDA revoked emergency use authorization, the use was nearly 0%. The second drug, remdesivir, which is depicted in purple color, the use increased in May. It reached around 10% and gradually reached to over 25% by the end of study period. The third drug, dexamethasone, which is depicted in orange color, nearly 4% of patients received dexamethasone before May. And this use increased rapidly, reaching to over 50% by November 2020, and then declined slightly by the end of study period. So the figure on the left shows dexamethasone use stratified by mechanical ventilation status. And you can see that the use was greater among those who received mechanical ventilation, which is depicted by green color, compared to those who did not receive mechanical ventilation, which is purple color. And the figure on the right shows the use of dexamethasone and other corticosteroids among mechanically ventilated patients. And you can see that in each month from July 2020 to February 2021, nearly 1 out of 5 patients did not receive either dexamethasone or corticosteroids. This figure characterizes variation in drug use across 43 health systems over time. The use of hydroxychloroquine use varied earlier in the pandemic, and we found wide variation in the use of remdesivir with ICC of 84% and less so for dexamethasone with ICC of 14%. Here this figure shows variation in dexamethasone use stratified by mechanical ventilation status. And the figure on the left shows that the variation across health system was higher among those who were mechanically ventilated with ICC of 25.7%. And the figure on the right shows variation among people who were not mechanically ventilated. The ICC is 13%. So there are many potential drivers of the treatment trends that we described. In the case of hydroxychloroquine, early enthusiasm and media coverage increased use dramatically. However, once we saw the evidence on ineffectiveness and potential harms and revocation of the emergency use authorization, the use declined significantly. For both remdesivir and dexamethasone, results from clinical trial led to increase in drug use, and remdesivir use was less common than dexamethasone. We found that nearly 1 out of 5 mechanically ventilated patients who might have benefited from dexamethasone did not receive this drug. These findings persisted in different sensitivity analysis. And few potential reasons for this underuse could be drug shortages, hospital policies, or generalizability of recovery trial to the US population. And finally, we saw a greater variation in remdesivir use, which could be due to potential drug shortages, evolving evidence on drug use, and for both remdesivir and dexamethasone, the variation across health system could be explained due to differences in patient characteristics, health system characteristics, or quality of care. So in conclusion, we found that brisk uptake and decline in hydroxychloroquine early in the pandemic has been offset by increasing use of remdesivir and dexamethasone. Dexamethasone may be underused among patients who are mechanically ventilated, and the use of both remdesivir and dexamethasone varied across health systems, suggesting variation in patient case mix, drug access, treatment protocol, and quality of care. And we would like to acknowledge National COVID Cohort Collaborative for putting this great resource for research purpose. Thank you, and I'm happy to take any questions.
Right. Thank you very much for that very interesting presentation and very clear. Can I start by asking, since I don't see yet any questions coming up, can I ask you regarding, you're stating here that there is a potential underuse of dexamethasone. Do you have any idea or speculation of why that may be? Have you mentioned for remdesivir that there could be shortages of drug. Are there any reasons why there may have been underuse of dexamethasone?
Yeah, one reason could be drug shortages. There have been drug shortages of dexamethasone that has been reported in the US. And as a reason, NIH guideline also recommends alternative corticosteroids when it's not available. It could be lack of clear and consistent message because there were a lot of evidence coming up. The other reason could be the generalizability of recovery trials to the US population. In the control arm, 26% of people died in recovery trial for dexamethasone, whereas in US, the rate of death was around 8%. So the very high rate of death in a trial would have led to some speculation that if results are generalizable to US population or not.
All right. Another question I have is, so what do you think, I mean, part of the trends you're showing are due to the way information, probably due to the way information was communicated about these drugs. What do you think could be improved in a future pandemic situation to optimize medication use for patients with a pandemic disease?
Yeah, that's a great question, and it's tough because this is like once in a century pandemic, and lots of research evidence came, and there was a great quote in Science. It's like we are building a plane as we are flying. And we tend to make mistakes. The good thing is, based on this study findings, it seems like clinicians quickly adopted when they learn if something works or if something doesn't work, like the case of hydroxychloroquine. What could we learn? Probably clear messages from regulatory agencies and CDC or NIH that could help clinicians synthesizing evidence from different studies, which can help clinicians improve their prescribing practice. Yeah, it's a hard to do.
Okay, thank you. No, I think those are good points. So thank you very much. There is one question here now. The figure shows that the use of DEXA was higher among mechanically ventilated. Does that mean that DEXA was used more frequently among the more severe patients? So was it not used commonly? What I mean is, could routine use prevent some mechanical ventilation?
And that's a great point. So the recovery trial results and the NIH guideline, they suggest that dexamethasone benefits patients who require oxygen support, and that may be the reason that it's used more among patients who are mechanically ventilated. The second question, would it prevent mechanical ventilation? So our study didn't address that question, but I think that's a good point, and some real world study. I'm not very much familiar with the literature, but that would address that question. And in fact, we are working on some research on that topic also.
Okay, so thank you very much. I think we need to move on to the next presentation now. Thank you.
Thank you.
All right, so our next presenter is Lawrence Rasulian, who's head of biostatistics and data sciences at Omni Health. And he will present on COVID-19 in children this time, treatment patterns in the real world hospital setting. Please go ahead.
Okay, thanks very much, Frederick. Can you confirm that you can see the slides?
Yeah, it's not the full screen presentation.
Okay.
Now
there we go. Okay, great. Thanks very much. Hello, everybody. And I think we've heard some really fantastic presentations on COVID-19, not only in this session, but in ISPE in general. And I think that it was on a lot of various aspects on COVID-19, but I think that one topic that continuously gets left out of the conversation, or at the very least is discussed a lot less frequently, is children and what's going on with the kids, right? So how are the kids being, what's their experience and how are they being treated? I was very happy to see that in the session previous to this one, there was, it was dedicated to children in COVID-19, but really more focused on outcomes and health policy, which I found fascinating. But here we'll focus on treatment patterns in the real world hospital setting among children with COVID-19. I don't have anything exciting or interesting to disclose, so we can get right into the background. I think we can all agree that COVID-19 treatment guidelines have been evolving continuously. If you can see here, I presented the National Institutes of Health, or NIH, here in the United States, their guidelines on the treatment of COVID in the hospital setting. Now, I'm not going to go into details on it right now, but one thing I want to call your attention to is that this is describing therapeutic management of hospitalized adults with COVID-19. I guess the key word here being adults, which brings me to the next point is that, most of the guidelines, and I would actually argue that almost all of the guidelines are targeted with adults in mind, simply because there's insufficient data in children, which is completely understandable. However, it really is not well understood what is happening in the real world hospital setting, especially among children. And that's kind of what we wanted to set out to address in this study. So here the objective is to characterize treatment patterns in children with COVID-19 in the real world hospital setting. So this is very much a very descriptive analysis, very hypothesis generating, kind of want to get a finger on the pulse, lay of the land type of study. We'll really just want to understand what is actually going on when a child comes in with COVID. How is that child treated at that same encounter? And we're going to focus our analysis on the therapy classes that were called out explicitly in the NIH guidelines, which we've listed here. But if you want all of the guidelines in their full glory, I've provided a link here at the bottom. But just as a warning, they're continuously changing. So what you see today might not be there tomorrow. So going from there into population selection, how we dove into this problem. So here's how we selected our population. We used electronic health records from 2 partners in the OmniHealth platform. Now I know the next question is probably, what is the OmniHealth platform? So I think I should give at least a 15-second explanation on that. But my company, OmniHealth, we partner with healthcare systems across the United States, and we go in and work with them and work with their electronic health record data, and we de-identify the data, tokenize it, and then normalize it into a common data model that's translatable across all of our partners. And so we selected 2 of these partners that we thought would be representative. One was a large pediatric network that primarily serves children, of course, and then the other one was a large IDN or integrated delivery network of hospitals that also had a pretty large proportion of patients that were children. And so we took those 2 data sources, we pulled them together, and we got about 1 million patients. And then when we subset on patients who had a diagnosis code for COVID-19 within the past couple of years, we get 11,552 patients, of which 2,570 were children, and about half and half split to when they were diagnosed, half in 2020, half in 2021, more or less. Now we also have information on approximately 9,000 adults within this population. It's not the focus of this analysis, but we have done that analysis, and so I may be making a few anecdotal comments here and there just about what those numbers look like, because it might be interesting to just kind of do that side-by-side comparison to see if there are any differences with the way children and adults are being treated. So what do our patients look like? Here are just some very basic baseline characteristics. We can see that our patients are slightly more female. In terms of racial distribution, we're seeing 48% white, 31% Black, and 21% other/unknown. So there, among the racial minorities, there is an overrepresentation compared to the US general population, which I think tends to be characteristic in COVID hospitalization. In terms of the age of the patients, we have a more or less 50-50 split on younger kids versus older kids based on decade of birth. So that's a nice mix there. Treatment setting, we're seeing almost half of the patients come in through the emergency department, 36% in the outpatient setting, 8% in the inpatient setting, and the remaining 9% is unknown. We weren't able to determine that. And then finally, medical history index. I just threw a few comorbidities up here. Cardiovascular disease, diabetes, chronic respiratory disease, which ultimately includes asthma and chronic bronchitis, cancer, chronic kidney disease. And these percentages actually did line up very well with the national prevalence of these conditions in the United States among children. So it's nice to have that bit of representativeness there from that aspect. So what did the kids actually get? So for the rest of these slides, I use this picture notation to describe the NIH guidelines. So green thumbs up means that the NIH recommended the therapy in certain situations, and I'll describe what those situations are case by case. Red thumbs down means that the NIH actually recommended against the use of the therapy. And the yellow question mark means that the NIH didn't have enough evidence to make a recommendation one way or the other. And so here we're looking at antivirals and antiparasitics. The thing that jumps out to me immediately is that the only one that's being administered to children is remdesivir, and it was administered exclusively in the inpatient setting. We're seeing 7% of those patients in 2020, and it jumps to 16% in 2021. So it's more than doubled between the years. And I probably think that might have something to do with the FDA approval of it. It's the only antiviral approved for treatment of COVID-19. And the NIH actually recommends it in situations where the patient requires supplemental oxygen. And so that's what we're seeing there. I can tell you that with the adults among this inpatient setting, we're seeing these numbers in this particular population around 50 to 60%. So there is a very stark difference there between kids and adults. The rest of the ones on this list, for the most part, the NIH is giving a thumbs down. And I think most of them, I mean, there's 3 antiparasitics and 1 antiviral for the wrong disease, actually, for HIV. And I think a lot of these, as Dr. Mehta said in his talk, I think towards the beginning of the pandemic had a lot more prevalence because, at that time we were thinking, how are we treating this disease? And I think clinicians were almost as an act of desperation thinking about some of these other ones. But we're not seeing any real administration among the children. We see a patient here or there, which is why you see little bumps in the colors, but not even enough to round up to 1%. So less than 0.5% in all of these. So no meaningful administration of these. And I think that's very much in line with the NIH guidelines for adults. Moving on to antibody products, and specifically anti-COVID-19 antibody products. The first three rows here represent monoclonal antibodies that target the spike protein in the virus in COVID-19. If I were to have given this presentation a few months ago, all three of them would have had a green thumbs up and it's recommended for treatment of mild disease. So if a patient comes in, is hospitalized, not yet requires oxygen, but might be trending in that direction, it's recommended in those situations. And more recently, the third row here got a recent switch to a thumbs down simply because of specificity issues with the latest variants of COVID-19. But in any case, the main takeaway is that we're not seeing any meaningful administration of these antibodies to children. Moving on to convalescent plasma, there was an excellent talk a couple of days ago with an emulated trial looking at its effectiveness. We're seeing only 2% among inpatient children in 2021. And the one I found the most interesting in this slide was IVIG, or intravenous immunoglobulin. In the inpatient setting, we're seeing it in 12% of children in 2020, but in 2021, it drops down to 2%. So there's a 10% drop there. And I wonder if that might be correlated at all with the near 10% increase we saw in remdesivir in the previous slide. Just a hypothesis, but it would be curious to see if one drug might be replacing another therapy or something along those lines. Among adults, I can tell you that convalescent plasma in this setting, we're seeing close to 50% in this population, and IVIG, almost nothing. So very big differences there. But in general, these are looking very similar to what the guidelines should be recommending for adults of what we're seeing in children. Moving on to immunomodulators, dexamethasone. This is the big one that's very prevalent across all recommendations. It's recommended for severe disease. So we were talking about this in the last talk, is that it's any disease requiring supplemental oxygen all the way to intubation. It's given the thumbs up by the NIH. It can also be used in combination with some of these other immunosuppressants, in particular baricitinib and tocilizumab. We're not seeing any real meaningful use, just a little bit of patients here and there. But what we are seeing with the children is that in the inpatient setting, 23% of patients are getting dexamethasone, and that jumps to 32% in 2021. We're seeing less of it in the emergency room, 5 to 7%, and then the outpatient stays around 2 to 3%. And this is also a proxy of severity, right? So patients in the inpatient tend to be worse off than the emergency department, which tend to be worse off than outpatient. So this trend does make sense. And also with the adults, we're seeing 3 to 4 times this amount of use of dexamethasone in this population in each of these different settings. And so that was an interesting observation there. In the interest of time, I can kind of go through this one more quickly. Immunomodulators, the other ones that were just mentioned explicitly. Basically the take home is the ones that got a question mark from the NIH, we're seeing in about 2% of patients, less than 1%, just here and there. We're not seeing observed use of many of the other ones that were given a question mark. And then the ones that were given the explicit thumbs down, some of these tyrosine kinase inhibitors and interferon, things like that, we're not observing any use among the children as well. So that was another interesting observation there. And then finally, moving on to antithrombotic therapy and supplements. There was an excellent session yesterday dedicated to anticoagulants and COVID, and lots of interesting discussion there. It actually gets a question mark from the NIH currently. I think the NIH says, we don't recommend it one way or the other, but if you're currently on it, we recommend that you not stop it just because you got COVID. And so what we're seeing in the kids is 21% of patients in 2020, and that dropped to 12%. In 2021. So that's an interesting observation there. Vitamin C or D, just as a supplement, as adjunctive therapy, we're seeing around the 10 to 11%. And then finally, zinc, we're seeing a little bit, 1%, and then jumping to 6%. So that's an interesting observation there. And with the adults, we're seeing a lot more use, especially of antithrombotic therapy, at least 2 to 3 times much in the inpatient setting. So that's pretty much it in terms of conclusions. I think these results really do help provide a little bit of insight into the real world treatment patterns among children. At the very least, it's a snapshot and kind of a first step to generate other hypotheses and other studies that we could look more deeply into and tie them to outcomes perhaps. We did observe that most therapy administrations were in the inpatient setting. And then I think the main take home is that what we observed in the children in terms of their treatment patterns did line up pretty well with the NIH guidelines for adults, with the caveat that among children, there tends to be just less therapy utilization altogether. And that itself could be a proxy for less severe disease. I think in the session previous, just before this one, Dr. Kimberlin gave a lot of interesting explanation of some previous studies that showed how symptoms were less in children, and just the severity of disease in general, on average, tend to be less in children than in adults. So that could be what might be going on with these trends here. And as with any study, additional analyses are always insightful, especially as the treatment guidelines evolve and as the pandemic evolves. And really, it would be interesting to see how this disease is managed among children. And with that, I will stop and hand it back over to the moderators, and happy to take any questions now or at the end of the session. Thanks.
Okay, thank you. Yes, I think we have a few questions now that we can take directly. One question here, there are a couple of questions in the questions and answers. So how many newborns entered the sample is one question.
That's a great question. Unfortunately, we don't have that information. The level of granularity we had was simply by decade of birth. And so I guess we could extrapolate that information, but unfortunately, we couldn't tell that detail.
Okay.
Due to privacy issues.
Although, I mean, the 2 decades were about the same size, right? So
right.
You'd assume that each age year is approximately the same size.
Right. Well, we would assume a distribution, I guess, similar to the national distribution of age. Yeah.
Okay. And next question: in your data, do the outcomes of children follow the race ethnicity outcomes in adults? Did you look at that at all?
We did not examine outcomes in this particular study. On a separate study, we did look at some of the outcomes, but we didn't break it down by race at this moment. But that's a work in progress. But it is a super interesting question, because as we've seen over and over, is that the outcomes tend to be worse for racial minorities, and there is definitely a distribution by socioeconomic status. So it's most certainly an interesting question that I'd like to address eventually. Yes.
Yeah, and I don't know if Chris would like to comment on this one, if he wants to do it now or later. No. Okay.
Sorry. Yeah. The thing about virtual conferences is one can have a snack in between presentations.
I'll join you.
Yeah, no, that is very true. So we published out the Veterans Health Administration in the U.S., which is the largest integrated healthcare system akin to the NHS in the UK. The racial and ethnic disparities nationally, and we found something that was very interesting. It's very true that in the U.S. Overall there is a significant disparity based on race and ethnicity for overall COVID-19 outcomes at the population level. But what we were able to define in the VA data was that when you stratified the population into the time, the stages of infection. So amongst those who tested positive, amongst those who test positive, who had bad outcomes, the disparities were primarily driven, at least in the VA, by the excess risk of infection, of testing positive, and not amongst those who test positive, subsequent death. That is not able to be demonstrated in other health systems, more private-based health insurance systems in the US. But it is very fascinating what's going on based on race and ethnicity worldwide, but particularly in the US based on access to healthcare.
Okay, nice comment. One final comment, then I think we need to move on. So there's a question here about the severity of COVID among the patients that you're showing, and also whether the 2 time periods in 2020 and 2021 were the same. Was it the spring during both years, or was it different length of time periods?
It was the entirety of 2020 and what we have as of, I think, a couple of weeks ago for 2021.
And the severity of the COVID in these patients, did you have data on that?
Well, we didn't have data on severity. I think the only thing we can use that really as a proxy for severity might be exactly this, the treatment pattern, and use of things like remdesivir and dexamethasone.
Thank you. All right, with that, I think we move on to the final presenter. And so we have now Matthew Reynolds, who is VP of Real World Evidence at IQVIA, who will talk about the persistence of COVID-19 symptoms 90 days post-acute infection, insights from a community-based registry.
All right, thank you, Frederick. Well, and in addition to having snacks during these remote conferences, you can also get booted from your workspace and giving a presentation while kneeling on a floor, carefully positioning your laptop on a bed. So we'll see how this goes. Today, I'm going to give a quick talk on the persistence of COVID-19 symptoms. We'll actually look at various time points, but all the way up to 90 days post-infections. This is from a community-based registry.
Matt, we're not seeing your slides now, so if that's intended, then
let me try to reshare this then.
Should be a green share button at the bottom somewhere.
There was. It worked in practice, didn't it? I cannot even get this.
Is there not a green share button?
I can't even get Zoom to. Oh, there we go. Let's get this back up. I do have share screen. Let's share this. Let's try again.
Now we're getting something.
And let's try again. It was working beautifully for me. I could see it before, but you know, that's fine.
Okay, great. Thanks.
There we go. So I think I've provided this introduction here already, but I'll dive into more details here soon. Let me see if I can make this small so I can actually read my slides. I also have very little disclosure. I do work for IQVIA, and they were the sole sponsor of this registry that I'm going to talk through. It's been used with FDA and with other some other pharmaceutical companies, but there's no personal or financial gain for me for this talking about this registry. I do want to thank my colleagues, a list of them here, especially Lisa Albert and Kendall Nuth, who reran some analytics at the last minute for this presentation. So I think most of us here, given we've been talking about COVID here for what, an hour and a half, is pretty in tune with the pandemic and understanding that as the pandemic has rolled on, we're realizing that many of these patients who've had COVID-19 are experiencing their symptoms over a longer period of time. They're not all resolving quickly. In fact, more than half of them may have symptoms beyond 30 days. They may go on to be long haulers, have long COVID, a variety of different terms with this. But the fact is that many of the symptoms don't seem to resolve quickly and/or tend to linger. So the aim of this study was to look in this registry that I'll talk through here in a second, and examine what the pattern of symptom progression and resolution look like over time. The original abstract, I do want to note that it will not align with all of the results that we had here. Those results in the abstract that are likely published in PDS and in your brochures and such only had data through February. I actually had this updated with data through July. So we've got the full insights here. So what is CARE? CARE was a registry that was quickly built in the spring of 2020. I think it launched in April as the pandemic was hitting the U.S. As we realized that many of the real world data sources that we'd be leveraging or hoping to leverage for insights into COVID and effectiveness of treatments and outcomes may have some shortcomings with regards to this specific infectious disease. In that, while you can see here from what I call the rainbow head and the blue head. The rainbow head represents, the real world data sources that we typically would leverage, where we know we'd get information on age, gender, medical history, prescription medications, and healthcare utilization. But we anticipated that there may be some questions along the lines of things like ethnicity and race, information on COVID-19 symptoms, severity, persistence of that over time, use of supplements and non-prescription medications, symptoms associated with vaccines, the symptoms associated with vaccines. So this registry was put together not just for COVID patients, but for those who believe they've been exposed to COVID. We wanted to be able to make sure we had information both on those who were symptomatic, actually were diagnosed and confirmed with COVID, as well as those who thought they'd been exposed, so that we would have some comparators here. And for those who are not in the United States, I'm sure this varies by country, but keep in mind that throughout the course of this pandemic, especially in the early 3 to 6 months, testing was not always available. It was hard to come by. And so there were many patients and participants in here that didn't necessarily get tested. And hence, when I talk through the COVID positive patients here, it will be a subset of the patients in this registry that actually were tested and confirmed. It's an online registry. You can see the www.helpstopcovid19.com. It's open to all. It is not incentivized, although there was one study that had a subset of patients that received a very, very small incentive to participate in a 30-day symptom study. We have over 30,000 patients, follow-up for over 12 months. This also was a change in the pandemic. I think we started with a 3-month follow-up and quickly realized we need a lot more follow-up for these patients because the symptoms were not going away. And then this data is also linkable to claims and such, although I will not be talking through that today. Just a quick snapshot of what the registry looks like. At enrollment, the survey is a bit longer, but still very manageable. I think it's maybe about 10 minutes to pick up information on demographics, occupation, high risk occupation information, things like healthcare, whether they're a healthcare worker, their medical history, their medications that they're on, basically a summary of this patient. And then we also at baseline collect information about whether they'd been tested for COVID, when they'd been diagnosed with COVID, did they experience COVID symptoms? If so, which ones? And we do provide prompts for these. And then, what is the severity on a severity scale that was provided? Eventually, over time, we also included information on vaccines that was implemented in January of 2021. And we follow these patients or participants every about 2 weeks and 2 to 4 weeks. They're reminded via text and via email. And then we have the ability to follow these patients up and check their vital status if they become non-respondent as well. I should note, especially given the prior presentation, that these are adults greater than or equal to 18 years old. So we do not have children in here, although there are some, there is a question that asks about other people who are living in the household, especially when there's a COVID positive case. So we'll get into the data. I know epidemiologists like data, and this here is just a snapshot for what the COVID positive patients look like in this registry. Like I said, there's over 30,000 patients in this registry currently. Over 5,000 of them actually were tested and had a positive COVID-19 test. You'll see the average age is about 42 years old. A higher proportion of these are women, almost 80%. They're fairly well educated with, you can see here the number that have 4-year college or more than 4-year college, primarily Caucasian, 73, almost 74%, although we do have about 20% ethnicity on Hispanic. And then, you can see a couple of the other characteristics here. But as expected, given that this is an online, social media push enrollment for the most part, it's likely made up of people who have the time to be able to complete a survey and or the interest. And you can see some of the slight skewing here for some of the demographics. So what symptoms were reported and how did they positive for COVID, and what that looked like at day 7 and day 14. So the light blue bars are the baseline, the blue day 7 and the green day 14. And you can see about 2/3 of the patients had reported fatigue. More than half of the patients reported congestion and cough at baseline. The decreased sense of smell, decreased sense of taste, both are between 40 and 50%. Aches and pains, the SOB about halfway across there is shortness of breath. all very common symptoms for these patients. And you can see at day 7 and day 14, for many of these, you see a fairly good drop where either a quarter to a third, sometimes a half of the patients did not have that symptom that they had a baseline at day 7 or day 14. So, a few of them less likely to resolve the decreased sense of smell, decreased sense of taste, fatigue, some of these hallmark COVID-19 symptoms, shortness of breath. And then if you go off to the right, confusion or trouble waking up, not as much improvement for some of these. Now this one shows day 90, so 3 months out. You will also notice here the N drops to 721 patients. So this is limited. Again, this was not an incentivized study for patients, so they were doing this on their own accord. So there is potential that there could be some bias here. Are people who are more likely to have symptoms, completing the survey? Possibly. Are people who have the most severe symptoms not able to complete the survey? Possibly. I'm not sure exactly where the bias would go, but these were patients who continued to complete the survey and provided a survey at around day 90. And you can see, again, the light blue is still the baseline symptom prevalence. But if you look here at day 90, these dark blue, you still are seeing, 22% of patients reporting fatigue, 10 to 13% of patients still reporting aches and pains, decreased sense of smell, decreased sense of taste, shortness of breath, and then still almost 10% reporting confusion. And in some of our write-in boxes, there was oftentimes written in word for word as brain fog. So there is still a fairly high level of symptomatology here for these patients at 90 days. In fact, as you can see on the slide here, 87% reported at 90 days still experiencing at least one symptom. So while some of these are down to 10, 20%, overall, almost all of these patients still had something that they were reporting at 90 days. Now, given I know I'm speaking to epidemiologists, I had another slide added that was not included in the abstract, and that is looking at patients who were COVID negative, because I wanted to I wanted to provide some sort of comparator here with regards to what patients look like at their symptoms over time. How do we benchmark this? Is this just a natural resolution of symptoms? Would other participants also report similar symptoms who were not COVID negative? And you can see here that something like fatigue, even in the COVID negative patients, you can see the fatigue was still, about 20%. So is this COVID fatigue? Is it associated with the pandemic? Or is it associated with having COVID specifically? It seems to be similar in both the COVID negative and the COVID positive patients. But there are a few that you can see where the yellow boxes are, where there is some notable difference. Decreased sense of smell, decreased sense of taste, shortness of breath, confusion did remain higher for those that were tested COVID positive compared to those that tested COVID negative at 90 days. Interestingly, there are some symptoms that actually were reported with a higher prevalence for COVID negative patients. Those like aches and pains, congestion, cough, runny nose, diarrhea. These are what I would likely classify as flu and cold types of symptoms. So these participants were symptomatic enough to get tested for COVID, and they may still have some symptoms at 90 days, but they're not necessarily COVID symptoms. They didn't have COVID then, and they're still reporting these symptoms. Something else was underlying, but they seem to be a differential list of symptoms being reported for those that COVID positive and COVID negative at 90 days. So just want to highlight, if you guys are interested in the CARE registry, this is a publication that was, this was our first publication that really highlighted the symptoms that differentiated COVID-19 positive patients versus the COVID negative. And we have another one that just came out really looking at long COVID and differences in those with autoimmune disease, COVID positive versus those that did not have autoimmune disease. So if you are interested, feel free to feel free to take a look at those, and I'm happy to answer questions.
Thanks, Matt. We've had a very interesting session here, afternoon session on the last day. I think it's been very lively. We are running a little bit late, but if we have any questions, I think we should try to fill them before we are thrown out of the room. So at least there is one question here. For day 7 to 14, how did you differentiate the symptoms with suspected drug ADRs?
We didn't. We didn't conduct any attribution to drugs. We do ask about treatments, but no analyses here were focused on trying to associate any of these symptoms with drug treatment. It's something we definitely could look at. We did ask these as COVID-related symptoms, although obviously treatments for COVID could also be, assumed to be COVID-related treatments. I mean, COVID-related symptoms. So something we could definitely look into.
Yeah. Christopher, did you want to add something to that?
Thanks, Frederick. No, we do have another question in the chat from Michelle. Do you think higher rates of symptoms reported by COVID negative patients may reflect selection bias? Those patients who fill out the survey are doing so because they have a symptom to report.
Yeah, absolutely. And I think that's definitely a possibility. And one of the reasons why I wanted to provide some sort of comparator for the participants in the COVID positive cohort that actually lasted 90 days and were still reporting, because I wanted to find out, are they more likely to be participating because they're symptomatic? And the negative ones could be as well, but we can at least, if we go with that assumption, we can at least, I think, be comfortable in saying, there's still a differentiation even between those who feel like they're symptomatic and are reporting because of that. There is a difference in the content with regards to the symptoms that are being reported in COVID positive and COVID negative patients.
So how long do some of the patients go out now in reporting in your data?
We have some that have been followed for a year, but as you can imagine, when you're not providing incentives, there's the drop off is fairly rapid. So it would be single digit that we have passed, 3, 6, 9 months, and per our IRB approval for this registry, I think we're capped at 12 months at follow up. Although we're exploring, re-engaging many of those patients as well, given the difference in the pandemic between March of last year and and even March of this year.
And you very briefly mentioned in the beginning that there was a possibility to link this to other data. Could you say a few more words about how that is possible and whether you will actually move on to do that and follow them in other data sources?
Yes, we do have the data has been linked, and we're actually going through the process of doing it a second time. We've linked it to open. Spoken on this many times they're not perfect because you don't have all of the data for these patients, but they do color the medical history. They do provide you insight into prescription drug treatments quite well. It's the outpatient and the inpatient where, again, it's not going to be perfect for an incidence-based type of analysis, but we can link this, and we have linked this to IQVIA's open claims data. About half of the patients link to that data set, higher if you just went with prescription data. And we can look at information on, more specifically on oral drug exposures. We can look at confirmed medical history related questions. We could also look, depending on how we set up parameters, at some sort of event-based analysis. Again, if we put parameters on about continued some sort of continued follow-up period.
Okay, thanks. That might be interesting to have some data that are not so dependent on.
And we're open to folks collaborating, even academically here. We're lots of analytics going on, especially with vaccines right now. So, and their side effect.
All right. Was there any other? Yeah, there's one more question. No. Oh, yeah. Number of, no. Okay, I think we should finish off now. We're out of time, and I think we've had a very nice session, which has spanned everything from really a potpourri spanning from baseline rates to the pandemic itself and detecting COVID to treatments for COVID and then long-term COVID. So thank you all the presenters for these very interesting insights, and thank you all participants for joining this session.
Thanks very much.